Hello, and welcome to ID Talk, Answers from Infectious Disease Experts. I am Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you happen to be looking at the thumbnail of the podcast, Dr. Price is the illustrious young man on the right, and I am the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. We've taken the last few weeks off for the holidays, so thank you for tuning back in for the new year. This is the week of January 19th, 2026. Let's go ahead and jump into the questions. Our first question this week comes from a member who asks, I'm trying to understand the logic related to the 8-month limit on the RSV antibody. If a baby isn't 8 months on their first winter, I understand they're covered. However, if they don't get seen for their 4th or 6th month well-child check until after October 1st, but are still less than 8 months of age when they do have their well-child check, why are they refused by VFC to receive it? Now, I have to admit this question confuses me a little bit because based on what the member is asking, any infant less than 8 months old should still be eligible for monoclonal antibodies against RSV in their first year. So maybe I'm just misreading this question, but I think we can go through RSV and monoclonal antibodies, hopefully to get an answer to this question. First, we need to remember that RSV is the leading cause of hospitalization among infants in the United States. Most children here in the U.S. are infected within the first year of life, with about 100% of infants infected by RSV by 2 years old. When RSV infection occurs in older children and young adults, it tends to be more of a mild upper respiratory tract infection. However, in the first year of life, the virus can actually lead to a lower respiratory tract infection, which oftentimes presents clinically as bronchiolitis. Prior to the introduction of RSV immunization for pregnant women and monoclonal antibodies for infants, in the United States annually, there were about 50 to 80,000 RSV-associated hospitalizations and about 100 to 300 RSV-associated deaths in infants. We also know that the risk for severe RSV disease is higher among preterm infants, with hospitalization rates roughly 3 times higher and ICU admission also higher for those infants born at less than 30 weeks gestational age. However, it's important to remember that about 80% of hospitalized infants in the U.S. actually have no underlying predisposing conditions. I think we all remember that before the introduction of the more modern monoclonal antibodies, our only product for protection of infants against RSV disease was palivizumab, or Synagis, which was limited by its high cost and its need for monthly injections, which meant that it was only indicated for use in high-risk infants. Thankfully, in the last several years, we've seen big advancements in new therapeutics to prevent RSV disease among newborn infants. In 2023, a maternal RSV vaccination was approved by the FDA. This vaccine is called Abrysvo, and it's based on the RSV pre-fusion surface antigen. The second category of novel therapeutics is the newer generation of monoclonal antibodies targeted against RSV, including nirsevimab, which was FDA approved in 2023, and clesrovimab, which was approved in 2025. Now, the big advancement among these monoclonal antibodies is that they're engineered to have a longer half-life, which allows for single-dose administration in infants prior to or during RSV season, allowing for more broad use among the general population of infants compared to Synagis, which, as I mentioned previously, was only used among high-risk infants. When we look at how well the newer monoclonal antibodies work, for nirsevimab, or Beyfortus, studies have shown a pooled efficacy in prevention of medically attended RSV-associated lower respiratory tract infection of 79%, prevention of hospitalization of 80.6%, and prevention of ICU admission of 90%, with a cost-effectiveness estimate of $102,000 per quality-adjusted life year, or QALY. Now, I think it's important to remember that we assume an intervention is cost-effective if it's somewhere in the range of $50,000 to $150,000 per quality-adjusted life year. Studies have demonstrated similar efficacy of the second monoclonal antibody, clesrovimab, or influenza, with a 60% efficacy in prevention of medically attended lower respiratory tract infection, 90% against hospitalization, with a cost-effectiveness analysis estimate of $105,000 per quality-adjusted life year. Importantly, these numbers are very similar to prevention of infection and hospitalization among infants born to mothers who were vaccinated against RSV. Therefore, the monoclonal antibodies are only indicated for infants of mothers who were not immunized, or if that immunization was given less than 14 days before birth, with the presumption that the mother may not have had a robust immune response during that window. So for these reasons, the current recommendations for RSV prevention in infants calls for the use of monoclonal antibodies in infants who are less than or equal to 8 months at the beginning of or during the period of high seasonal RSV circulation, which in the United States tends to be between October and March, only among those infants whose mothers either were not immunized against RSV or who received it less than 14 days before birth. Now, it's also important to remember that because older infants with underlying conditions are still at risk for severe RSV disease, there are recommendations that infants who are aged 8 to 19 months old, who are at increased risk for severe disease because of chronic lung disease of prematurity, immunocompromising conditions, cystic fibrosis with pulmonary involvement, or Native American, Native Alaskan infants, should also receive a dose of monoclonal RSV antibodies in their second RSV season. So why then is it that we have a cutoff of 8 months for receipt of monoclonal antibodies? Well, this comes down to what it has been studied to prevent and just the natural epidemiology of RSV disease. So, for example, we know that infants who are older than 6 to 8 months are just at lower risk for severe disease based on their longitudinal age. There is a study from 2009 that was published in the New England Journal of Medicine, which demonstrated rates of hospitalization for RSV disease of 17 per thousand among infants less than 6 months, dropping to only 3 per thousand for infants greater than 6 months up to 5 years old. So because the main benefit of these monoclonal antibodies is prevention of medically attended respiratory tract infections or hospitalizations from RSV, and because the rates of these outcomes drops after 6 months old, that's the rationale for why these monoclonal antibodies aren't indicated for infants older than 8 months unless they have an underlying predisposing condition. So if you have an infant who did not receive a monoclonal antibody prior to the onset of RSV season, you can still administer it as long as they're less than 8 months, sometime in the window between October and March. If, however, that same infant were to show up and was 8 months old and 1 day, even in the middle of RSV season, our presumption is that that infant is not going to benefit from monoclonal antibodies because they're already old enough that they're not at risk for severe disease. So I think that may have answered the member's question, but going back to what they initially asked, they seemed to at least indicate that an infant who was less than 8 months old was still being denied by VFC for receipt of monoclonal antibodies. And at least based on current recommendations, that shouldn't be happening. So if that really is the situation where you have infants less than 8 months old who are being refused by VFC, please email back in with a little more context because it would be interesting to figure out what's been going on. I have not heard of this scenario happening myself, but not being a general pediatrician, I have to admit that I'm not the one administering these products as much as you all would be in the community. Now, one last thing I do have to point out is just this month, RFK Jr. and the leadership at the CDC changed the childhood vaccine schedule to make several immunizations, including monoclonal antibodies against RSV, now under a category of shared decision-making instead of recommended. Thankfully, at least as of now, current guidance suggests that vaccines considered shared decision-making are still covered by VFC, so at least this shouldn't cause financial burdens for our families. Okay, I think that's enough about RSV monoclonal antibodies, so let's move on to question 2. A member wrote in to ask, assuming the ACIP ends the newborn dose of hepatitis B vaccine, will that affect subsequent doses? In the U.S., with low rates of maternal Hep B infection, what impact will eliminating the birth dose have on subsequent newborn infections? Well, the good news is that if the birth dose of hepatitis B vaccine is not administered, it doesn't change the standard infant hepatitis B vaccine series. So if that first dose is missed, you still administer a 3-dose series, with the second dose being 4 weeks after the first, and the third dose at least 8 weeks after the second dose and 16 weeks after the first dose. Now, this is the standard schedule that most pediatric clinics work off of, so if you have an infant who presents and did not receive the hepatitis B vaccine at birth, you don't need to change the vaccine schedule that you're going to anticipate at the 2, 4, and 6-month well-child checks. Now, estimating what's going to happen after the CDC dropped their recommendations for the birth dose of hepatitis B vaccine is difficult because there aren't really any good examples of a country making a step backwards on their vaccine schedule to see what happens to rates of infection in a real-world scenario. But I think looking at what happens to rates of infection at the point when countries institute birth dose recommendations really sheds light on how important this dose of vaccination is. For example, in Taiwan, universal birth dose vaccination led to a decrease in chronic hepatitis B infection rates among children from 10% all the way down to 1% over a 10-year period, with concurrent reduction of 50% in childhood hepatocellular carcinoma. And here at home in the United States, since the initial universal recommendation in 1991, there has been an estimated 99% reduction of annual infections in children and adolescents, with over 500,000 childhood infections and 90,000 childhood deaths estimated to have been prevented. What's also concerning is that we don't know how relaxing the hepatitis B vaccine recommendations is going to impact either uptake of subsequent hepatitis B vaccine doses or even other vaccines in the recommended vaccine schedule. We do know from prior experiences, however, that relaxing of recommendations for vaccines does tend to lead to declining overall immunization rates in the general population. And with our current context of declining rates of immunization among children and an ongoing measles outbreak that's been going on for almost a full year, it's extremely frustrating to see these changes to the vaccine schedule, especially if they lead to further erosion of trust in vaccines from the general population. And let's be clear, these changes are not based on any new data, new studies, or new epidemiologic understanding of these diseases. These changes are unilateral decisions that are being made by the leadership at HHS and RFK Jr., without any input from CDC scientists, physicians, or outside experts such as the AAP. So I'll finish this question by just saying, if you're as frustrated by these changes as I am, and you are also as worried about the health of our patients, then I would say make sure you're reaching out to your elected officials and letting them know how upset you are. Which is a perfect segue into our third and last question this week, in which a member asked, with your experience, how should clinicians reconcile differing vaccine recommendations from various sources when advising families? Well, the first thing to say, and I honestly don't say this lightly, is that unfortunately I don't think we can look to the ACIP or messaging coming out of the CDC for accurate vaccine recommendations anymore. If anyone has watched the last several meetings of the zombie ACIP, since RFK Jr. stacked it with his hand-picked members, It's a mess, and unfortunately, I don't think we should be listening to anything that comes out of that group for the time being. So I would recommend looking to those professional organizations who we've known to trust. So, for example, the AAP at the national level has said they will be maintaining their own vaccine schedule. And I guess what I would say to summarize it quickly is trust the professional organizations that helped develop the evidence-based vaccine schedules as they existed last year before they were tampered with. But because the CDC has such a large reach with its messaging, I think we're going to have a lot of families over the next several years that are confused by the differing recommendations. So when you're counseling families, I think it's important that you start thinking about how you're going to frame for them why you follow the recommendations of the AAP, especially as they are hearing more misinformation and misguided recommendations from the CDC, HHS, and RFK Jr. And I will finish this question by pointing out that these are my personal opinions I'm sharing with you right now that may not necessarily reflect the opinions of the National AAP or AZAAP. So that's it for this week of January 19th, 2026. Thanks again for listening to ID Talk. AZAAP members can submit questions for future episodes to id@azaap.org. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.